Hello and welcome. Today we're diving into the world of the urinary system to explore a fascinating and often asymptomatic condition called renal angiomyolipoma, or AL for short. We'll unravel what it is, what causes it, how it's diagnosed, and what treatment options are available. So, let's get started. The exact cause of renal angiomyolipoma isn't always clear, but we know there are two main pathways. Most AMLs occur sporadically, meaning they arise spontaneously without a clear genetic link. However, a significant number are associated with genetic conditions, most notably tuberous sclerosis complex, or TSC, and less commonly, lymphangioliomyomatosis, known as LAM. These genetic conditions involve mutations that affect cell growth regulation, increasing the risk of AM development. So, how does an AML develop? Well, renal angiomyolipoma is a benign tumor composed of three main tissue types: blood vessels, smooth muscle, and fat cells. The underlying problem lies in abnormal cell growth and differentiation within the kidney. In sporadic cases, it's thought that somatic mutations that occur after conception are responsible. In TSC and LAM, the underlying genetic defects disrupt the mTOR signaling pathway, a critical regulator of cell growth, proliferation, and survival. This disruption leads to the uncontrolled proliferation of the characteristic AML tissues. Renal angiomyolipomas are relatively uncommon, affecting around 0.1% to 3% of the general population. However, the prevalence is significantly higher in individuals with tuberous sclerosis complex, where up to 80% may develop AMLs, often multiple and bilateral, meaning affecting both kidneys. Lymphangioliomyomatosis is less frequently associated with AMLs, but it still increases the risk. AMLs are more frequently diagnosed in middle-aged women, particularly sporadic cases. The tricky thing about renal angiomyolipomas is that they're often asymptomatic, especially when they're small. Many are discovered incidentally during imaging tests performed for other reasons. However, as AMLs grow, they can cause a range of symptoms. The most common is flank pain or abdominal pain. Larger tumors may also compress surrounding structures, leading to hematuria, which is blood in the urine, or even a palpable mass in the abdomen. A serious complication, especially with larger AMLs, is spontaneous rupture and hemorrhage, which can cause severe pain, shock, and may require emergency intervention. Diagnosing renal angiomyolipoma typically involves imaging studies. Ultrasound can be used as an initial screening tool, but it's not always definitive. Computed tomography or CT scan and magnetic resonance imaging or MRI are the gold standard for diagnosis. These imaging modalities can visualize the characteristic fat component of AMLs, which is a key diagnostic feature. In some cases, a biopsy may be necessary to confirm the diagnosis, particularly if the imaging is inconclusive or if there's suspicion of malignancy. While there aren't distinct types of AMLs, we can classify them based on their association with genetic syndromes. Sporadic AMLs occur independently, while syndrome-associated AMLs are linked to conditions like tuberous sclerosis complex and lymphangioliomatosis. Furthermore, AMLs can be classified by size and number: single or multiple, unilateral or bilateral. A rare variant called epithelioid AML exists, which has a higher risk of malignancy, but it's very uncommon. Treatment for renal angiomyolipoma depends on several factors, including the size and location of the tumor, the presence of symptoms, and whether it's associated with a genetic syndrome. For small, asymptomatic AMLs, observation with regular imaging follow-up is often the best approach. If the AML is larger, causing symptoms, or at risk of rupture, treatment options include selective arterial embolization, where blood supply to the tumor is blocked, partial nephrectomy, which is surgical removal of the tumor, or, in rare cases, radical nephrectomy, removal of the entire kidney. For patients with TSC or LAM, mTOR inhibitors like sirolimus or everolimus can be used to shrink the AMLs and prevent further growth. Unfortunately, there's no known way to prevent the development of sporadic renal angiomyolipomas. However, for individuals with tuberous sclerosis complex or lymphangioliomatosis, genetic counseling is important. Early diagnosis and management of these underlying conditions, including regular kidney imaging, can help detect and treat AMLs before they cause significant problems. The prognosis for renal angiomyolipoma is generally excellent, particularly for small, asymptomatic tumors that are managed conservatively. Larger tumors that are treated with embolization or surgery also have a good prognosis. The major concern is spontaneous hemorrhage, but with appropriate monitoring and treatment, this risk can be minimized. Recent research is focusing on improving targeted therapies for AMLs, especially those associated with TSC and LAM. Studies are exploring the optimal use of mTOR inhibitors and investigating novel agents that can effectively control AM growth with fewer side effects. This ongoing research offers hope for even better outcomes in the future.